Hello, and welcome to a very special series that I am moderating on diversity, equity, and inclusivity by CME Outfitters. This CMEO briefcase is entitled Racial and Ethnic Disparities in Cardiac Care, Real-World Strategies to Address Inequities in Treatment and Outcomes. This program is supported by an educational grant provided by Johnson & Johnson. My name is Dr. Monica Peak, and I'm the Ellen H. Block Professor of Health Justice in the Department of Medicine at the University of Chicago, where I also serve as the Associate Director for the Chicago Center for Diabetes Translation Research and the Director of Research and the Associate Director for the McLean Center for Clinical Medical Ethics. I'm really delighted today to be joined by my colleague, Dr. Sunil Rao. Dr. Rao, would you mind introducing yourself?
Yeah, hello. Thanks, Dr. Peak. I'm Sunil Rao. I'm Professor of Medicine at the NYU Grossman School of Medicine, and I'm Director of Interventional Cardiology for the NYU Langone health system. And I've been interested in issues around access to care for both coronary disease and other cardiovascular diseases. And I really am delighted to be part of this discussion today.
Thank you. Really excited to have you. Before we begin, I want to just note that this program was designed to build upon some foundational concepts that have been covered in previous DEI activities. To learn more about the impact of systemic racism on healthcare and health disparities, as well as how racial and ethnic disparities present in the field of cardiology, we encourage you to engage in these foundational programs, which are linked here. Now, before we begin, I want to clarify that as colleagues, Sunil and I have decided that we would refer to each other by our first names during this session. Sunil, I look forward to our candid discussion today. I'm really excited to have you here with us. Let me first start by reviewing our first learning objective for our program, which is to implement strategies to address inequities in the treatment and outcomes of patients with atrial fibrillation. So to start our discussion, I think it's really important to consider social determinants of health and patient care. And so just a level set for all of our audience members today, social or structural determinants of health, also known as the social drivers of health, are all of the things that determine healthcare that aren't directly medical factors, but they do include things like insurance and access to care. We mainly think about these things like poverty, food insecurity, transportation issues, education and employment, things that are in the social and built environment, exposure to violence and crime, all the things that determine people's health and their ability to access medical care. And so all of that determines how people show up for care and when they show up for care. And so, Sunil, I'm going to hand it off to you and have you begin the discussion about how these kinds of social and structural determinants of health relate specifically to atrial fibrillation.
Yeah, thanks, Monica. I think this is really, really important. I think the previous model was that our interactions with patients and our ability to diagnose and provide some kind of prescription or treatment was sort of when our interaction ended. And I think it's becoming really clear now that the success of the treatments that we provide or the understanding of the diagnosis that we may provide really is influenced by a lot of social determinants of healthcare. So, for example, in atrial fibrillation, many patients may have symptoms that are, a little unusual. They may have palpitations. They may be completely asymptomatic. So they may be unaware of that diagnosis. They may misinterpret those symptoms. They may have other, sort of social issues, family-related issues, cultural issues that prevent them from actually seeking care for, symptoms like profound fatigue or breathlessness. That limits the ability of the healthcare provider to actually diagnose atrial fibrillation in that patient. And once they are diagnosed, there may be structural issues around them accessing good treatment. And we know that the use of anticoagulation, for example, can dramatically reduce the incidence of stroke in this patient population. But even if they are, able to see you in clinic and you're able to provide that prescription, they may have challenges affording that medication. They may have cultural issues around taking regular medication and may rely on other home-based remedies because of the education that they may have had. And it's really, really important for us to keep in mind that as we interact with patients, understanding what those social barriers are is going to be a huge determinant of whether or not we are successful. Now, in atrial fibrillation, success is actually relatively straightforward. And how we measure success, right? We measure it by making an accurate diagnosis and providing that therapy that either gets that patient back into a regular rhythm or provides them with anticoagulation to reduce their risk of stroke. But if you limit your understanding to what treatment success is to those simple sort of check boxes, it really does limit our patient-related outcomes, which is really why we're here. I mean, it's not really about making the diagnosis or providing the prescription. Ultimately, the success is determined by whether or not that patient has an adverse outcome. And without taking into account these social determinants of health, that success really is limited.
That is exactly right. It's like all of these things are very important, but they're really important because they impact people's health. And the other thing that I wanted to just highlight is how each one of these things that may manifest is a direct result of structural inequities. So the two things that you mentioned that I wanted to just underscore were how patient symptoms may not seem unusual. So fatigue or tiredness, when a population disproportionately has 2 to 3 jobs, is working, the night shift, because they're, minimum wage workers, and they have to work, multiple jobs in order to sort of have a livable wage, they're going to always be tired, and so fatigue may not seem unusual for anyone in the family because of structural inequities. When people have limited access to healthcare, they can't afford expensive medications, or have systemically been, because of racial segregation or laws preventing them from entering white medical systems, have to figure out other ways to care for themselves, and have family-based remedies that have been passed down from generations. That is a response to structural inequities and structural racism. And so when people are presenting and we're like, why are they doing these things? We have to understand that the historical context in which marginalized people have been forced to live, and have that extra layer of empathy, that extra lens of understanding of the situations in which people have been forced to live, and how that impacts their life and presentation.
Yeah, I think that's absolutely right. And I think, we're also going to talk a little bit more about inequities in research and actually generating evidence in these underserved populations so that it can inform our clinical care, which I think is also really, really important. It should be a priority for those of us who are involved in clinical research.
Absolutely. So let's think about this in clinical terms. So we have a couple of cases. We're going to go ahead and start right off. So Neil, would you mind presenting the case of Francisco for our audience today?
Yeah, absolutely. So this is, a case that I think many of us see. It's emblematic of cases that we see probably all the time. This is a relatively young patient, 40 years old, born and raised in the Dominican Republic, identifies as Hispanic Black, really has limited, education. Health literacy status is really unassessed, and we don't do that systematically, unfortunately. During our interactions, we use a lot of medical terms, and patients, want to be polite. So they may not actually ask, what do you mean by that? Or they may feel a little bit inhibited about demonstrating their own lack of health literacy. So it's really important to think about that as we talk about this case. You can see that the patient does have risk factors, right? Their blood pressure is elevated. Their BMI is high. This is his first time seeing a cardiologist after being seen in the ED for atrial fibrillation that was incidentally discovered after he went in after a motor vehicle accident. So this patient was in the ER for something completely unrelated to a cardiovascular diagnosis. And then on the monitor, had atrial fibrillation discovered. And, because the ER is focused on the MVA, they said you should probably go see a cardiologist to get this atrial fibrillation addressed.
You should probably have that checked out.
Exactly.
So it's really important to consider disparities in atrial fibrillation treatment once a patient is diagnosed, because this person was only diagnosed, like you said, sort of incidentally. Someone else who may have been a well-established patient likely would have had an EKG for their blood pressure, would have been picked up much earlier and treated much earlier. So can you talk about disparities in treatment for atrial fibrillation?
Yeah, absolutely. And these have been documented. So we know, for example, based on studies that have been done, that Black patients, patients of Hispanic or Latino descent, Indigenous patients are less likely to be treated with rhythm control or catheter ablation. So there's a whole aspect of atrial fibrillation treatment that involves procedures. And this is true across the board, not just for catheter ablation, but even for invasive procedures for coronary disease, for example, or bypass surgery. These groups are historically less likely to be referred for those invasive procedures. And we're talking about patients who are actually appropriate candidates. It's not that they're not candidates for these procedures. They're just not referred as often. We also know that, our reliance on sort of a one size fits all dosing strategy sometimes is not appropriate. So, for example, and there are large registries that have been run by the American College of Cardiology called the NCDR Pinnacle Registry. It's an outpatient registry. If you look at those patients who have a CHAD score greater than or equal to 2, so this is very, very high risk for stroke, okay? A risk that we know we can decrease with the prescription of anticoagulation. A large proportion of those patients, greater than a third, were treated with just aspirin, which we know is inadequate treatment. So, in cardiology, we think of undertreatment as basically no treatment, right? Mm-hmm. Because so if you're giving someone aspirin, you're really not decreasing their risk of stroke appropriately. Now, some of that is because, the healthcare provider may say, well, I'm a little worried about bleeding risk in this patient. This patient has a job where they're doing a lot of manual labor. But the reality is, we know that those risks are really overestimated, particularly in groups that are underrepresented. So these are patients who, really should get adequate anticoagulation. Now, in the old days, we only had warfarin, and warfarin required a lot of monitoring. That is very, very challenging, for patients who may have limited access to healthcare, limited access to transportation, and quite frankly, just have very, very busy lives, maybe balancing more than one job, maybe balancing a family to come in to get their INR checked. Thankfully, now we've got newer agents that don't require monitoring, but there's another aspect of access to that, which is whether the patient has health insurance. Are they able to afford these drugs? So these are the kinds of things that I think lead to these disparities in atrial fibrillation treatment. And I think being aware of this is really just half the battle. We have to address them as well, but I think it starts with the awareness.
Absolutely. So let's take this understanding back to our patient, Francisco, and see how this applies.
Yeah. So this patient was sent home from the emergency department with a prescription for warfarin. We just talked about how that, is probably not the best treatment. This patient has frequent cramping in his right leg. So for a cardiologist or someone who's interested in vascular medicine, you start thinking, geez, is this claudication that really has not been diagnosed previously? Oftentimes these patients, if they see a doctor, will say, I'm having some leg pain when I walk to the mailbox. And the answer they sometimes get is, okay, well, don't walk to the mailbox then. Or they get a prescription for a scooter, right? So instead of actually taking that next step, so the cardiologist in this case does the appropriate thing, calculates the CHAD score of 2 with hypertension and PAD. So that factors into the CHAD's VAS score in addition to the AFib. Clearly, this patient is at risk for metabolic syndrome. And, this patient says, I didn't start the warfarin that they gave me the prescription to because he didn't know why he needed the medication. He was in the ER for a motor vehicle accident. Mm-hmm. So, this is a great opportunity for this cardiologist to provide the appropriate education about what the diagnosis is, what the risks are. Because again, remember, this patient is asymptomatic. They feel fine, mm-hmm. right? So it's important for us to tell this patient, to tell Francisco exactly what the risk of having AFib is and how we can decrease that risk.
Excellent. And I think that this idea of how we translate numbers and risks, all of that is always a challenge for every specialty and for us as primary care physicians to patient populations, regardless of their level of literacy. Like translating proportions and all of that stuff is part of the challenge of being a physician. But specifically related to CHAD score and clinical guidelines and risks of stroke, what have you seen as far as how that translates into disparities and gaps in practice and how that may be related to the case that we're discussing?
Yeah, this is great. I want to point out a couple of things on this slide because I think they're really, really important. First, this is a simple score that, I sort of carry around on my phone because, no one likes to do math, right, in the hospital. So you want to make sure you have it accessible. But I want to point out a couple of things. The first is female, just being a female gives you a point on this. And that's really important. We know that women are undertreated, and it is clearly part of this risk score. So if you have a patient who's a female in front of you, realize that actually gives them a point on this scale. The other thing I want to point out to you is that aspirin alone is nowhere on this slide, right? So we talked about how a third of the patients with a CHADS VAS score of 2 or greater, and that puts that patient to a high-risk category. Aspirin is not adequate therapy. If you're going to use aspirin, you should use it in addition to something else. And you can see how, a CHADS score of 0 is very low risk, 1 is intermediate risk, but once you hit that 2, that's when that patient really is very, very high risk. and needs to have first-line therapy with oral anticoagulation. Again, we prefer now what is called the NOACs or the DOACs, the new oral anticoagulants, not so new anymore, direct oral anticoagulants or DOACs, because they have been shown to be just as effective as warfarin with a lower risk of intracranial hemorrhage. So, I think that having this at your fingertips to calculate these scores and showing patients what that means is going to be very important to not only increase the educational level for patients related to AFib, but I think it will help adherence as well if patients realize why they're being treated.
Exactly. I think that your point about the responsibility being on us to give that information to patients. We talk about health literacy, but really the only people who are fully health literate are clinicians. We should not expect our patients to have the same literacy as we do because they didn't go to medical school. So it's our job to make sure that we have transmitted the information at a literacy level that is at the grade school. So we have to figure out how to, take these complex terms and make them understandable, as we say, like to your grandmother or to my, teenage children. It's not the patient's job to sort of, escalate their knowledge level to be able to talk to us. So thank you for that. So let's check back in and see how Francisco's doing.
Yeah, so this is a great slide because I think, I live in New York, tremendous amount of diversity, cultural diversity in the city. Make sure you have an interpreter, right? When you interact with, that's a fundamental basic thing because again, patients may be very reluctant to tell you that they're not understanding what you're saying. They may smile and nod, and the message really hasn't gotten across. So, the healthcare provider here, the cardiologist, make sure that they have interpreter services are available. He or she calculates the Has-Bled score. He or she discontinues the warfarin and starts the DOAC, implements that ABC pathway to consider the comorbid conditions. And I think, importantly, educates Francisco about exactly what his condition is, why they're prescribing the DOAC, because he was very candid and said, I didn't even start this because I didn't know why I needed it. And then, again, considers these other comorbid conditions that can ultimately improve not only his quality of life, but make sure that he can potentially even live longer if he meets some of these goals.
Perfect. Yeah, and I think that that's one thing to also consider, that when people are sort of rightfully getting started or treated for other conditions when they're seen in the emergency room, the ER docs are not necessarily, they're in the emergency room. They have, they have other emergencies coming in, and they may not have the time to sort of fully say, okay, you have this complicated cardiology condition, and let me take the time to explain to you about all what this is, and this is why you're taking warfarin, et cetera. And so, but that is important for patient adherence. So making sure that our patients are fully on the same page, that sort of shared understanding, shared decisions is really key to patient adherence. We're going to move on to our second learning objective, which is to implement strategies to address inequities in the treatment and outcomes of patients with complex cardiovascular disease. So, Sunil, like atrial fibrillation, I'm sure it's important to highlight disparities in the diagnosis of cardiovascular conditions in racial and ethnic minority patients. Can you highlight some of these disparities for the audience?
Yeah, I mean, look, cardiovascular disease is still the leading cause of death, right? And so I think we know that certain individuals in certain groups are even at greater risk from dying because they don't get diagnosed as often. And again, this is all tied up in some of these social determinants of health. Even after you adjust for some of these socioeconomic status issues, access to healthcare, non-Hispanic Black people are still 12% less likely to have adequately controlled blood pressure. Data show that primary care doctors, unfortunately, are following race-based recommendations for prescribing ACE inhibitors and ARBs. We're finally getting away from that race-based calculation of GFR. Thank goodness.
Just like the past year or so.
Yeah, exactly. It's amazing how it's taken this long to sort of get away from that, right? So, I think because of that, they have a higher adjusted risk compared with their white counterparts, cardiovascular death, myocardial infarction, stroke, heart failure, et cetera. So, this is a problem of both diagnosis and treatment, but it's also a problem of prevention. Because when we see patients coming into the hospital with their index MI, we realize that they have risk factors that are very, very poorly controlled, may not have even been diagnosed. Diabetes, it's not unusual to see someone who has never been diagnosed with diabetes come in with their first infarction and have a hemoglobin A1C of 8 or 9, right? Because again, they're not able to have access to that care. They have other issues that may prevent them from seeking care. They may have limited health literacy. And then if they do have, if they are aware of what these risk factors are and are making attempts to see physicians, they may have difficulty in transportation to the doctor's appointment. They may have difficulty in affording the medications. So again, keeping all that in mind is really, really important. We just talked about it with AFib. I would argue it's just as big an issue, if not bigger, for vascular disease, stroke, myocardial infarction, PAD. I spent a large part of my career in North Carolina, which is part of the U.S. amputation belt.
I had not heard of that.
Yeah, it's unfortunate, but in the South,
yes,
there is a tremendous amount of PAD that is occurring in Black patients and Latino patients and in the indigenous population. I think that's because of again, those social determinants of health that are limiting their ability to access care and the high rates of risk factors like smoking.
So let's take on another case that will help sort of think about cardiovascular disease other than AFib. Can you introduce our case of Samantha?
Yeah, this is a really, really important case. So this is a 45-year-old female, again, younger than what we would expect, born in Florida, identifies as Black and indigenous. She's 5'7", weighs 230 pounds, BMI is 32. Blood pressure when she comes into the ED is markedly elevated, right? 153/97. She presents to the ED with abdominal discomfort and some episodes of confusion that she describes as just sort of a foggy feeling, right? So she's evaluated. She's diagnosed with anxiety and a UTI based on a urine sample that was obtained. And, part of that evaluation, she's pointing to the upper part of her abdomen. And so they say, geez, this might be some chest pain, but why don't you go see a cardiologist, because we've got a full waiting room full of patients that we need to see. She's referred for cardiology, where she continues to feel sort of dismissed, right? Because here's a patient who's a young female, has been seen in the ED with abdominal discomfort. We have a diagnosis. This is a UTI. Just take your antibiotics, you'll feel better. This is really straightforward. This is not a cardiology problem. Okay. Mm-hmm. That's what she's told. And so this is a really, really important case. And I want people to pay attention to this because, the issues here are she's a female, she's from an underserved population, and pay attention to her symptoms. And I think we'll get into the sort of the meat of what this is in just a second.
Yes. So why don't we talk about why this is really important? And I think the fact that she felt like she wasn't being heard is there's a national conversation happening right now about Black women's experiences of not being heard in the medical doctor's office and what that means for their health. And so talk about some of the disparities in the diagnosis of patients with complex cardiovascular disease and the ways that they may present differently and what that means ultimately for their outcomes.
Yeah, absolutely. So, we know that, 40% of patients with AFib are asymptomatic. It gets picked up incidentally, like the previous patient that we talked about. But the other thing is that remember that not all patients read the textbook, right? So they may present very, very differently. And it's important to have a high index of suspicion when someone comes in. So, for example, in this particular patient, her abdominal pain was sort of misread as being part of a UTI, right? So she never really got that evaluation with an EKG. There's probably ascertainment bias in AFib because we think of the AFib patient as being an older patient, right? We know that there's an epidemic of AFib because the population is getting older. But yes, it's not everybody with AFib is elderly, and not all elderly patients will have AFib. So again, keeping that index of suspicion high and making sure that you're making sure you're not leaving any stone unturned. Now, from the clinical trials perspective, it's very challenging because we know that the clinical trials that have been done tend to undersample certain groups. We struggle to get above 30% representation of females in our cardiovascular clinical trials. For Black patients, it's even worse. Indigenous patients, it's very, very challenging. Now, the perception has always been that, those groups don't want to participate in clinical trials. But what we're learning now is that it's actually because they're not approached for clinical trials. And so, it's important to make sure that we have representation in our clinical trials to make sure that we understand if there are differences in treatments that we have available across these patient populations. And again, in a patient like this patient that we're talking about, Samantha, she's a female, she has elevated blood pressure, she is obese or overweight, and she has some sort of unusual symptomatology. So this is a patient where you certainly don't want to dismiss what her findings are, lest you actually miss something that may be important.
Mm-hmm. All right, so let's follow the case and see how she's doing.
Yeah, so as expected, the UTI was treated, but she continues to have these symptoms. And, on further questioning, if you sort of delve into that a little bit more, she not only has that abdominal discomfort, she has fatigue, she has palpitations, she has these panic attacks. Further questioning, they may or may not have even asked in the emergency department, does she smoke? Does she drink alcohol? She endorses both. So the cardiologist appropriately assesses the CHADS score, comes up with a score of 2. So this patient is high risk for stroke. And when you first read that description, you never would have thought that, right? Here's a young female coming in with abdominal pain. That's a UTI. Who's even thinking about stroke in this patient? But we know that when we start quantifying those risks, that this patient is a high risk for stroke. So the cardiologist appropriately obtains ambulatory EKG monitoring or a Holter monitor or a loop monitor. And it notes paroxysmal AFib. That is consistent with her symptoms of when she has these episodes of confusion or these so-called panic attacks. So appropriately, she starts DOAC treatment, orders imaging, stress testing to make sure that her abdominal pain is not angina, appropriate laboratory studies, and other diagnostic tests to make sure that her cardiovascular system is completely assessed and is not written off as, it's all in your head, or this is just, there's no way you could have cardiovascular disease because you're a relatively young female. That is important bias that we have to overcome.
Absolutely. Absolutely. Are there other considerations for her care that you can walk us through?
Yeah. So again, it's important for us to make sure that we have a holistic approach to this, right? And many cardiologists or specialists may think, look, I'm going to stay in my lane here. Okay. I'm going to diagnose that AFib. And look, you may not be an expert in treating diabetes. You may not be an expert in managing weight, but at least recognizing that those are issues and making sure you communicate with the primary care physician or send to another specialist is important. So this cardiologist appropriately says, patient has high blood pressure, is overweight. These things go along with type 2 diabetes. Let's just get an A1C. It's elevated. It's 10, right? This patient has those episodes of confusion. Let's get an MRI or some kind of cerebral imaging. This patient's already had, evidence of a TIA. So now the CHADS score is even higher, right? It's not just 2, it's 5. It's very, very high. Yes. So, of course, this patient is going to need further evaluation for polyvascular disease, an entity that we're starting to become more and more aware of. So, CAD, CVD, PAD. So this patient will discuss getting further imaging with a CTA, a coronary CT scan. And then, of course, that cardiologist appropriately wants to make sure that they're closing the loop. So she communicates with the primary care team to make sure that the other comorbid conditions are adequately addressed, and also initiate services with a case manager to make sure that the patient doesn't fall through the cracks of our health system.
Yay, the cardiologist talks to the case manager. That's team-based care. That's what I'm talking about.
Yeah, that's really, really important.
Sunil, what a wonderful time I have had with you today. This was such an excellent discussion. Just thank you so much for all that you're doing for your patients in New York City and for the patients or for the clinicians that are with us today. I'm going to try and summarize our discussion with SMART goals, which are specific, measurable, attainable, relevant, and timely. And so that's what I hope that our audience will take away from this presentation and apply to your own practices. The first is to identify disparities in the diagnosis and treatment of atrial fibrillation. The second is to integrate holistic treatment strategies into the care of patients with atrial fibrillation to improve treatment outcomes. Third is to identify disparities in the diagnosis and treatment of patients with complex cardiovascular disease. And then last is to integrate holistic treatment strategies into the care of patients with complex cardiovascular disease. So this CMEO briefcase is one of a 4-part CME CE initiative, and we really hope that you'll take advantage of and participate in all the activities in the series. These activities cover strategies that address racial and ethnic disparities across therapeutic areas. And I really encourage you to join us for the entire initiative. It's really going to be great. By participating in these activities, you demonstrate your commitment to improving health equity for all patients. The CMEO D&I Hub also has a number of resources available that we have really been sort of building up over the past several years to help you further your own education on diversity, equity, and inclusivity. And so, Sunil, I just really want to thank you again for joining us today and for having just a wonderful, robust, and authentic conversation about these issues.
Oh, well, thank you. It was really a privilege to be part of this.
All right. To receive your credit for this activity, please complete the post-test and evaluation. We really do appreciate your feedback. We tailor our future programming based on it. We want to hear from you. Tell us what you liked, how we can improve, and what additional topics you'd like for us to address. And I just really want to sincerely thank you, our audience, for your commitment to diversity, equity, and inclusivity. Because all together, we can strive to provide the best and most equitable care to our patients, particularly those who are most marginalized and underserved. Thank you all so much for being with us today, and have a wonderful day.